Welcome everybody to this new webinar by the Global Plan Council. My name is Isabel Mendoza. I will be here helping in the organization of this webinar. Today we partner away again with the Safe Cassava International Network. But before I introduce our moderators for today, let me explain for the people who are new what are the logistics of these webinars. You are as attendees can can write in the chat. You can really use this feature, but for the questions for the speakers, please use the Q&A tool that is in the bottom bar of your Zoom device, because it's the chat tends to be too active and questions get lost there. So in order to ease our work during the Q&A session, please use the Q&A tool. At the end of the webinar, we will have this set Q&A session, not after each of the speakers' talks. So please wait until the end. What else? In the coming week, we will send the certificates of attendance for the people who came to the webinar and stayed at least 1 hour with us, and you will get that in your email under your the name that you register into this webinar. So that's all from my side. Thank you again for being here. And I will leave the floor to Professor Gleadow, who is the moderator for today's session. And she is the convener of the Safe Cassava International Network. And Ross, the floor is yours.
Good. Well, thank you, everybody, for coming today. If you're looking at the video, you'll see that I'm with someone else here. And it's my great pleasure to have with me this day Professor Dr. Julie Cliff from Mozambique, who's also, we're in Melbourne and in Australia at the moment, but it's fabulous having her here today. And she will also be able to help answer some of the questions that we have coming into the Q&A. Just a quick thing about the Q&A. I noticed on mine it didn't automatically show, and if I had to go to the thing that says ... more to find the Q&A tab. So just have a look at that. Now, I just want to introduce what we're here today. Thank you, Isabel, for that introduction. So I'm from the International Safe Cassava Network, and this is our webinar series that we've been holding in collaboration with the Global Plant Council. Also on the line is Bethany English, who is our secretariat, and you can see there. So if you contact the network on our email, the info@theiscn.org, Bethany is the one who will answer. Kira, who was doing this before, for those who know, has moved on to a different job, and we miss her greatly. I'm Professor Gleadow. I'm a professor of plant science at Monasch University in Melbourne, Australia. And I got interested in cassava because I work on plants that make cyanide. This connected me with Julie Cliff, and then I discovered the seriousness of this disease, Konzo. So it is fabulous to be partnering with the Global Plant Council for this. I did spend 4 or 5 years as president of the Global Plant Council, and they do a wonderful job. If you don't know what they do, connect with them. So what's the network? Now, clearly, you're not going to be able to have time to read all of this, but this has been recorded and will be available on YouTube. But the aim of this network is to really build on the legacy of Howard Bradbury, who did so much work in the area of understanding Konzo and the relationship to cassava and cyanide and the other complexities. And our aim is to really foster collaboration, interdisciplinary collaboration between people of different backgrounds, the knowledge exchange, the education of both end users and health professionals, because it's much bigger than just end users, raising awareness of this problem, which it generally slips a bit off the radar, and also to inspire a new generation of researchers. We've had 6 webinars to date. This is part of our education of various professionals, and for some reason, there we are. And you can view those previous webinars and others from the Global Plant Council, and also the symposium that we ran last year from the International Safe Cassava Network on the Global Plant Council YouTube channel. There's no charge for these, for either the symposium or the webinar, but if you would like to make a donation to the Konzo Prevention Fund through the Australian National University, that is the QR code there. We get a small donation of them each year, which enables us to employ Bethany a couple of hours a week to give this administrative support. So you've heard enough from me. Today, we've got a really, really important session. We've got the global evidence on Konzo incidence and mortality, and what by Litos, Raimundo, and Elsa Maria Salvador. And this is...
Ross, you're muted.
So muted myself there, so apologies for that. We have Professor Litos Raimundo and Elsa Marie Salvador, and they are reporting on the work they've done for the World Health Organization on the burden of disease for Konzo. And this is not an easy thing to do. And so they'll each talk for about 20 minutes. And then we'll have a Q&A facilitated by Dr. Isabel Mendoza from the Global Plant Council. Dr. Litos Raimundo is a public health researcher affiliated with Fernando Pessoa University and Portugal, and also has worked a lot in Mozambique, and in fact is currently in Mozambique and will be displaying from there. He's done a lot of work on neurological diseases and neglected tropical diseases in Mozambique. You can read more of that at a later time when these slides become available. Then after he's spoken, we'll have Elsa Maria Salvador. She's a researcher at Eduardo Mondlane University in Maputo in Mozambique, and her specialty is nutrition and food safety and cassava science. And so they bring these different perspectives on what's been very complex, as to try and work out exactly what is going on with Konzo in the current environment. So without further ado, I will pass over to them. And Litos, if you would share your slides, and we can move on to that. So thank you for your attention, everybody.
Thank you, Professor Ross, and also thank you to the Global Plant Council, as well as the International Safe Cassava Network. Thank you for giving us this opportunity to share a bit of what we did on this global evidence on the incidence and mortality. And I will present on the incidence part, and Professor Elsa will present on the mortality part. So we are looking at the global incidence from 1990 to 2023, and also we try to show what it misses or what has been published so far. So a bit of background, and thanks, Professor Ross. You have given a bit of how we came to realize this systematic review. It was commissioned by WHO under the Food Disease Burden Epidemiology Reference Group, FERG, and it specifically addressed the incidence of Konzo as well as mortality associated with Konzo. That's what we're looking in the literature that we were that we're looking into. So the research questions for this systematic review were: what's the global epidemiological profile of Konzo, including incidence rates, geographical distribution, and mortality trends from January 1990 to December 2023. And also we're looking at the regional variations in Konzo incidence and mortality rates across different socioeconomic and geographical contexts between January 1990 and December 2023. Well, maybe a bit of what Konzo is. It has been also widely defined, but I think it's important to mention that the word Konzo is coming from a language that's also spoken in the Democratic Republic of Congo, called the Aka language, and it means tired legs. And also it has been interpreted in so many local languages, including Mozambique. In northern Mozambique, it's called Mantakaza, and it has been published with this designation because people call it the way they see people behaving. It's an epidemic paralytic disease that causes irreversible spastic paraparesis, a permanent stiffening and weakening of the legs. You can see the graphic representation on your right-hand side. It was first described in 1938 by Dr. Giovanni Trolli in the Belgian Congo. So he discovered he saw the disease and described it and also published a book on the disease. It's linked to insufficient processed cassava. We shall talk about it later on, and deficient protein intake. It's a sudden onset, and the vulnerable groups for the disease are mainly children older than 2 years and younger women, especially in their reproductive ages, in low resource rural setting mostly. The connection with cassava is mostly connected with beta cassava containing cyanogenic glycosides that it releases hydrogen cyanide when improperly processed. And most of the studies we find, they also involve intake of beta cassava. How it happens, it's insufficient processed cassava, soaked less days than it was supposed to. And soaking less days, it fails to remove the toxic cyanide compounds that are there. And combined with protein deficient diet in sulfur amino acid, the body cannot detoxify cyanide in order to prevent the disease. It affects the motor side. It's sudden onset of symmetrical spastic paraparesis. Legs affected more than arms. Walking on balls of feet with rigid legs. It affects also sometimes the sensory part and speech, occasional blurred vision, speech difficulties in severe cases, and tingling or burning of legs. Uh, uh, it's abrupt onset, but not gradual, and disability is permanent but not progressive, and severely varies from mild, moderate to severe cases, depending on the intake that's happening. So WHO commissioned this review because no prior synthesis of global incidence and mortality were carried out. There was some review that was carried by Professor Julie before, but it didn't go up to 2023. So they wanted the update of that review. Because the disease is still causing permanent disability and remains neglected, though not listed in the list of neglected diseases by WHO. And the central question was how much of the burden is reported and how much remains hidden. This is what we try to look into when we were doing our systematic review. So we looked at 6 databases, mostly PubMed, Web of Science, Scopus, Embase, but we also looked at the Gray literature, which included Google Scholar, as well as the reports, especially Mozambique. There are a lot of unpublished reports that we have looked into that were carried out, especially in the northern Mozambique in Nampula. So the coverage, as I mentioned, is 34 years from 1990 to 2023, December. And we included, after say, I think we reviewed, we have found more than 3,000 papers that were written in our search. That was based on our search criteria, but we only found 37 studies that we included in the in the systematic review. These studies varied from cross-sectional studies, outbreak reports, reviews, as well as great literature, as I mentioned before. We didn't find new places. Mostly are the places that were reported before, special in this map that that we can see here. In Mozambique, in Tanzania again, DRC, Zambia, Angola, Central African Republic. There were some intoxication cases that happened in Uganda and in Nigeria, but didn't meet the WHO Konzo parameters in order for us to classify as Konzo. So the DRC documented evidence since 1938, but we have found a lot of cases from 1990, and they are still seems to be ongoing by the recent research that we're having. Now, Mozambique, we have found a lot in 1980, 1990, as well as 2000, as recent as 2021. Some cases were reported there. In Tanzania, there were some outbreaks from 2002 and 2003. In Central African Republic, also there were some reports that went until 2000s that were well documented. And then we have Cameroon, Angola, and Zambia. Zambia, I put in red because there were recent cases that were also reported, though they were out of scope of our study in 2023. But most of the cases were documented in 2020. Reported cases, we have seen they are only a fraction of the visibility that we have had, and the less than 70% of the burden captured is captured in published reports. Peer-reviewed literature reported close to 3,700 cases by 1993, and the case increased by 2009, even went beyond 2012 in some studies that we have found, mostly in Congo. Unofficial estimates suggest that at least 100,000 cases globally by 2000, and one estimate suggests more than 100,000 cases in DRC alone in 2002. In some cases in Mozambique, even we have found from 2015 to 2017, we have found cases that went beyond 30 and 40 and until 400 cases in some districts. Prevalence varies sharply across communities, typically in villages we can find from 1 to 30 per thousand. And then we find also other extremes that like the ones found in Tanzania, 14.1 per thousand that we find in a radius of 5 kilometers place. And we found other variations like 7.5 prevalence in one village in DRC, and high localized risk linked to ecology, food systems, and processing practices. Now, the question that we're asking is Konzo increasing? Well, evidence suggests that Konzo has increased substantially since 2009. But is not documented consistently. And the likely drivers continue to be the cassava monoculture, drought, insecurity, and persistent poverty, and lack of protein intake that would suppress the cyanide reactions in the body. There's a data gap. True incidence rates still missing. Most studies report prevalence or outbreak counts, not case per person per year. So it was difficult for us to extract the real case in some of the studies because of these variations in the reports that were happening. Recent reports, as I mentioned, Zambia, continual incidents rather than a purely historical problem. So from 2020 until 2023, there were some suspicions that were cases there, but now in 2024 we confirmed in Zambia. The risk factors still continue, as I mentioned, to be a drought and food shortage, low protein intake, conflict and displacement, that's happening in northern Mozambique and DRC now, that prevents people from diversifying their diet, and inadequate processing, especially in this conflict and displacement situations. People don't have enough time and alternative foods to process properly in order to prevent the disease. Why underreporting? We have seen that since the cases are happening in remote areas, mostly geographical isolation, no formal surveillance in remote rural areas, low diagnostic awareness, confused with cerebral malaria, sequels, spinal cord disease, sometimes confused with polio. So there's not enough training of health professionals to really diagnose the disease. Not a notifiable disease in most affected countries, so governments are not having this regular surveillance of the disease, and they are not even having in their list of disease to be surveilled. And publication bias, epidemics published, persistent and endemic Konzo invisible. So there is lack of publication, especially in places where they are affected, even formalization of the publication. Prevention that we have seen in the studies we have looked, we saw that soaking cassava roots continue to be one of the best ways of preventing it, including the wetting method. And these ones are the cheap and accessible methods in the rural and poor communities. But the diversification of diet continues to be a recommendation and prevention method that would really contain and suppress the onset of the disease, as well as community education. These are not new things. These are the things that has been recommended before, and they are still recommended by researchers currently. Treatment, well, the disease is not curable once the disability comes in. So the remaining prevention, the treatment methods, we need to prevent. Prevention is critical, but and then we need the physical therapy for those affected. I was working with NLR, and we have seen that physical therapy really reduces greatly the capacity of the mobility of people and also the functionality of people. It should continue being applied. Occupational therapy, speech therapy for those who have problems with speech. There is current research that's happening that we have also found during this review, especially some later studies, that there are some biomarkers that are being identified, significantly reduced in Konzo patients, that could somehow help people identify those who are prone to the disease. The worthy method that's also the Australian National University is also trying to promote, as well as the nutritional status of nutritional status that is being promoted by some countries, including Mozambique. Well, the key takeaways, we still think that Konzo is preventable. We could avoid having this permanent paralysis, primarily affecting children and women in reproductive age. The disease results from a toxic combination of cyanide from improperly processed cassava and protein malnutrition. Simple low-cost processing methods could avoid the onset, and addressing poverty, food insecurity, and access to diverse diets essential to eradicating Konzo, as well as continued research into biomarkers and disease mechanisms offer hope for better prevention and early detection, especially harmonizing the research part. So thank you very much. I hope I captured most of our funding, but we are still publishing the full report that have the details. I'll pass now to Dr. Elsa, who will present on the mortality part. Thank you.
Thank you. And morning for everyone. You can hear me?
Yes, we can hear you, Elsa.
Okay, thank you. It's a pleasure to have this time to present our research on Konzo, and it is a privilege to have this floor with Professor Jules. Prof. Jules was one of my teachers at the university. Thank you to have you here, and thank to have all of you in this floor. I think Litos was the one who should have more time to present because it starts with all the methodology we had in perform this study. And my part will be the mortality, risk factor, and research priority in this review we have done for the WHO. As we can see, we can take action for things that we know, and sometimes what we don't know should kill us because we don't know the cause of this. And this study try to see what it can kill us, or if Konzo could kill us, and what we can do to prevent the mortality because of Konzo. This will be the outline of this presentation. As it was said by Litos, in our review, we include only 37 papers. In these papers, we only found one study with mortality data. But in this study, we don't find population estimated base. If we don't know, to prioritize because it's the thing that we don't know and we could not measure. As we can say, we would, in this study, we want to measure the mortality. We should have mortality data, but within among 37 studies, only we have one study with mortality data. Only one study, that one report from 1991, it's only data available in Konzo worldwide. It means that only one study should give the figure of mortality about Konzo worldwide. And this in the range of almost 22% of mortality because of Konzo. But in the interpretation of this data, we have to be careful because some data or some death or some mortality may reflect acute cyanide poison. Also may not report mortality from Konzo alone. It means that other condition could be counted in the mortality as this condition, it takes long, it is a chronic disease, and some disease can come up and it can be counted as mortality about Konzo. As we see, this started from 1991. It is only the evidence, empirical evidence, the direct evidence of mortality about Konzo, because there is no evidence or the direct evidence about Konzo. We can search for the mortality about Konzo using indirect accountability. This indirect accountability of mortality about Konzo may be substantial using gray literature, as we said in the beginning of this presentation, that we use peer-review papers, but the reports also we use, and other information that can give us the figure of incidence and mortality about Konzo. For example, the study made in 1990, it reported about 50% of mortality. And this mortality, it may reflect poor access of care of those people or suffer from Konzo or other condition which can be related or associated to Konzo or to drought or to malnutrition on protein. That was found in gray literature. But we can say that there's a warning sign or are serious, but there's no evidence. The evidence could be exist, but it's not sequential. It is fragmented. And it can be well followed to collect all the thematic way. The mortality figures or the research and systematization of mortality, it's important because it can make visible this condition, and who it is responsible could make action in treat, prevent mortality. As we know, the priority in all the condition or in all disease is about in dial, but in Konzo, for example, the dial is not measured as well, and this Konzo is make permanent disability, and it take people for long consequence. There is long leg, and it affects the life for mortality about or without data for mortality in this condition. We can't fully estimate, and we can't fully make action to mitigate or to prevent or to treat as well this condition. Thus, we can say that no mortality data, we cannot have the band of this estimation, and it could not make the visibility of Konzo among all the research and among the government and all the institutions that can make action with regard of this condition. The risk factor was already mentioned by my colleague. As we say, it's the low rainfall. The low rainfall is related to droughts. This is associated with the pandemic or with the Konzo. The low protein intake or the deficient intake of protein. This reduces the ability of people with this condition to detoxify the cyanide that is in the beta cassava. And this beta cassava that is consumed in the stressed season, like low rainfall, it means that there's these people are stressed and are exposure to cyanogenic and could not because they not use the real method or the proper method to process cassava. As we say, it recommends to process cassava in 2 or in 3 or 4 days of processing with wet method. But people, as they are shortage with food, they are only consumed without the proper method. These factors, as we can see, are the same for the incidence of Konzo and also are the same, are contributed also for the mortality. It means that it's the same risk factor for the 2 parameters. Konzo epidemic in some part of Africa, as we say in the Democratic Republic of Congo, Mozambique, Angola, among others, are chronic and are all the condition in this part. But in 2020, it was reported an outbreak with 32 cases, and this outbreak in Zambia, as my colleagues say, it is still reporting cases of Konzo in Zambia, and the main population affected, or the vulnerable population affected, are mostly children from 6 to 14 age. We found also 14 women 14 age women affected, included women at breastfeeding. And it means that there's a more place we can find the reporting of outbreak of Konzo, which includes Zambia and Angola. It suggests that there is continued active Konzo and developing in this place. More place can report if there is surveillance of Konzo. Maybe we can find more place reporting Konzo as we can see in Konzo. There's a thing what we do not know. It was not known, for example, the population-based estimate of incidence, include of the mortality. As we say, for mortality, for example, among all studies we search or we reviewed, we only find one. But with mortality, but in the reports and the other estimates not pre-reviewed, we found all. It means that there is a need of more research and more surveillance of Konzo in order to find the data estimates of Konzo. The surveillance, it is not standardized, and no climate based early warning model. There's no model related to climate in order to see if real in the drought season or in the rain season, there's some cases are reported, for example. it is not no percent, not epidemic remain poor. It means that Konzo remain not measuring as well as it necessary to take action about the Konzo epidemic. There is a gap evidence. In this gap in the evidence limit the prevention and the policy response of these conditions. After our review, we recommend the integrate Konzo in the routine surveillance system, use of verbal autopsy in sentinel place, scaling up the prevention, special the use of weighting method, because many report it said that this method could remove cyanogenic glucoside in the rate that the cassava could be consumed without Konzo or making people poison with cyanide. Strengthen the active case funding beyond outbreak, and advocate the inclusion of the global banding estimating of Konzo for Konzo. It means that we move from the, if we can follow this recommendation, we can move from the hiding problem to measure public health and make it a priority and making action for that. The intervention could be done in 4 dimensions. It should be done by the government, WHO, the funder, and the recession. For example, for the government, they could make Konzo notifiable. The WHO could provide standardized case definition and surveillance. The research can publish the incidence and the mortality. It means that, for example, in Mozambique, we have many reports, but these reports are made at hospital level, but are not well reported at the national level and worldwide. The funder should make Konzo as priority funding for surveillance of incidence and mortality, and this will make the Konzo measure up. It means that the measurement of the Konzo is the first step for the prevention and make visibility of Konzo and take action or intervention for this disease. In conclusion, Konzo mortality is still a large unqualified. We saw that it is only one study that figured the mortality of Konzo. It means that with only this one study, we could not estimate the burden of Konzo worldwide. The Konzo's real fatality, and without the estimation of Konzo, without the data of mortality, Konzo, it will remain hiding epidemic. In final, Konzo is not only the negligent disease, it is a negligent measurement problem. It means that there's a negligence in measuring Konzo, both incidence and mortality. And this absence of measurement in Konzo make this disease hiding, it not prioritized, and no intervention is made on this. Thank you very much for your attention. Obrigada.
Yeah, thank you very much for that, Elsa and Litos. That was just absolutely fascinating. I think Isabel is going to handle the actual Q&A that's written. If you can enter them through that Q&A button at the bottom of your screen if you're on the Zoom. If I couldn't see mine when I came in and I had to click on the three dots that said more and then I could find the Q&A button then. So have a look for that. Isabel, can I start by asking a question?
Sure. Go ahead.
So you can hear me okay? So for Elsa, I just thought it was interesting. It's how can you tell the difference between death from Konzo and death from the acute cyanide poisoning? Is it possible to tell the difference?
Yes, we can tell the difference because Konzo is the poison of Konzo by cyanide. The cause of this, the poisoning that people give origin of Konzo, they make people disabilitated in the leg, and the other cyanogenic poison can affect other parts of the body.
Thank you. That's very helpful. Julie has a question.
I just had a question about some of the data that you presented. I think beginning in the year 1990 seems a bit strange because, in fact, the first cases of Konzo in Mozambique were identified 10 years earlier than that. So I think there needed to be more recognition of that fact. The other thing is, in terms of the getting rid of the cyanide question, it's not only soaking that's important, it's also for how long it can be soaked for. It's not just putting it in water. So it's more than just soaking. There was one very early paper by Telescore and company that showed that Konzo appeared in certain areas where there were droughts or particular problems of malnutrition. And I've never seen that paper or article reproduced. And I think it would be interesting to do that. So I think there's a whole lot of questions here. And many of them just come down to the fact that Konzo is a disease linked to poverty, and diseases linked to poverty don't get a lot of attention. Thank you.
Yeah, that's great, Julie. And I think it also in our symposium, I think when Dulcie gave her presentation, she said Konzo is invisible because the people who have it are invisible. And I just thought that that's really sad to have seen there's so few papers. Like Litos, you were saying there was only 37 papers that met the criteria. I mean, for such a major illness, that's incredible. Can you comment on the number of papers? Were you expecting to find more?
Yes, Prof. We were expecting to find more, especially because there was a kind of momentum, especially Mozambique, and then in Zambia, the first discoveries were expected, and even we contacted Professor Siddiqui, who is now living in USA. We asked them after his paper in 2020, was there any follow-up, any papers that were reported? He said, unfortunately, no paper, but the cases were there. As for the comment of Professor Julie, yes, we found a lot of papers prior to 1990. we fail to understand why WHO wanted only that parameter from 1990 in order to estimate the burden of. And what we found that there is no much government push for the data. That's why the cases are there, but there is no data. And if there's no data, that's what Prof. Elsa said, no burden estimate can be done. And if there's no burden estimate, there's no visibility. And no visibility, there's no action, even including from the WHO themselves. When they commissioned this systematic review, it's obvious they wanted to have data in order to take action. But I don't think we have come up, especially on mortality, with enough data that warrant really for WHO to take action. It's only, I think, last year in November that we reported 16 deaths in Angola, but it was on a newspaper bordering Namibia. And I'm still following up on those cases where they have been published, and it seems that the Minister of Health in Angola is the one who reported it, and the journalists reported in the newspaper. But it's true, it's a disease of the poor, and there is no much attention to it.
Thank you. I'll pass you over to Isabel now. I think I've taken my share.
As you should. So let's start with the Q&A, with the questions in the Q&A tool. So the first one is by Primitiva Mboyeva. I hope I said your name right. So I think it's more like a comment. Low soil fertility is an important factor linked to Konzo because it affects cassava nutrition and cyanide content, but it's not the only cause. Specific soil chemical conditions can also increase the likelihood of toxic cassava and therefore the risk of Konzo. So does anyone want to make a comment on the comment?
I can comment briefly as a plant scientist that yes, this is absolutely true, and we know that composition of the soil and particularly water holding capacity and ability of plants to extract water, whether the plants have got mycorrhizae on them, all affect the cyanide potential of those plants. And it's more than just that the plants are smaller, and low fertility. It's just that it seems to be that it's as part of their response to stress is that they actually make more cyanide.
Oh, second
Yes,
one.
I think
Litos, do you want to comment? Please go ahead.
Yes, I think Prof. Ross is right. It's just that we're not deep into looking in soil composition in this systematic review, but we have found papers that were stressing. And in fact, in Mozambique, there are an example that they took some cassava seeds to place where they are drought prone, like the northern Mozambique, and they became bitter, which means the soil composition contributed a lot to that. But we found very few, apart from the study that Prof. Jules also mentioned, and some other, I think 2014, that mentions also the linkage between the climatic conditions and soil conditions and cassava onset. I think it's an area of research that we need to intensify. Thank you.
So next question by Matthew Bramble. How would we consider mortality from Konzo? The disease itself or the fact that one is disabled when they are more vulnerable? For example, if someone with Konzo dies of malaria, this would be death from malaria, correct?
The condition here, as we say, it's a chronic condition, and people could live long time with this condition, and along their life they can be exposed to other conditions like malaria and so on. And as we say, these people getting Konzo are poor people and are malnutrited. They have deficient nutrition. They are not diversify their food, and they are exposed to other conditions along their life. It means that forgetting that these people are really there because of Konzo, it needs a specific follow-up of these people to say that these people in the acute, for example, period, they can die because of Konzo, because along the life they can live more than other people without Konzo. If we can have any study that we can follow all the symptom and the signal of Konzo and see where they can lose their life, we can really say that this is Konzo mortality, because it's a chronic condition and people could have another condition like malaria, tuberculosis, and the other.
Okay.
Maybe adding on the response from it's I think longitudinal studies could establish correctly if it's a Konzo-related death or not. We have seen some studies from Prof. Julie, Cliff, and others that have followed some communities, especially I think is member or Mojinkwal, that were following to follow up or to see where from the first diagnosis and the time it took for the people to if they were death or not. Though there were some deaths that were not, it was difficult to relate to connect directly to Konzo. But I think further studies on that we need to increase in order to establish the disability lived years that people are doing. Thank you.
Thank you. So next is a question by Thorkil Tilska. World Health Organization has published a case definition in Weekly Epidemiological Record number 30, 26 of July 1996. Does it need to be redefined according to you?
I think it doesn't need unless the new studies on biomarkers and other studies that could identify are concluded. But otherwise, I think is the governments themselves have to own it and also include in their routine surveillance, as well as training their public health officers, especially the frontline public officers, in order to clinicians, in order to diagnose the disease, as well as separating from the other diseases that are confusing the proper diagnostic of Konzo. Maybe I would say like that. I don't know the position of Dr. Elsa on that.
Yes, I agree with you. Mainly in the government honor, it's very important because they have to make a differential diagnosis to other disease. The criteria are good, but they should be honored and be implemented to make it happen.
I think that's very true. So there is a follow-up by Thorkil Tineskar where he lists the criteria for diagnosing Konzo, but I think that's complementary to what you were discussing. So I think that's. Do you think that still applies, or else? Do you want me to read the full question, or can you read it?
I can read it. Well, there are three that I mentioned. Yeah, they still apply. They fully apply. Yes, at least for the new cases that now we have seen the reports in Angola. There were most of these criteria that were followed, and they apply. Yes.
Thank you. Then we have a question by Luis Abayomi. To what extent is testing a constraint in monitoring the disease?
I'm not sure if I understood the question. Oh, it's testing a constraint. Oh, yes, it is a big constraint. As we mentioned, also my direct experience in the field, because we have also I worked in the communities in surveilling Konzo, is a big constraint. The clinicians, nurses, the frontline public officers, they don't know the WHO criteria to separate Konzo and let's say polio. There's a lot of confusion. So testing is a constraint to diagnose of the disease.
Well, that makes sense. So we don't have any more questions here in the Q&A tool. Ross, do you have anything else to ask? Now it's your moment.
I don't have any other questions to ask. Julie, do you have anything else to ask?
No.
No. Do we want to close it off there, Isabel?
Yes, if you want to. Yes, we
So,
can.
unless anybody else has any other questions to ask. It's been fantastic to see so many from so many different countries. Thank you so much for putting that in the chat. I think it's very rewarding to realize that we have many people from many different countries who are concerned about this problem, not just from Africa, but also from many other countries like Australia, where most people don't even know what cassava is. So I think this is really important, and I think the report you presented, Litos and Elsa Marie, is so important because not only have you shown that this is an ongoing problem and a serious problem, but you've also shown that we really don't have enough data. And I keep having in my mind that thing from your slide, Elsa. Basically, no data means no action, and how we really need to have data here. And I think I'm hoping that this network that we've created, Julie and I and others, will help raise awareness, because clearly that's what's needed, and to take this interdisciplinary approach of neurology, plant science, we've got public health, and also food systems and diet. These all go together, and it's always hard to tackle these problems, but I think we show how important it is. So I really want to thank you, Litos and Elsa Marie, for that huge amount of work. I know how much work it was because I was in contact with you when you were doing that work, and we really appreciate what you've done in that WHO report. And we will have another webinar in February, in January. What am I getting? July. I think it's the first or second week of July. We have yet to finalise the person speaking, and we'll have another one in November. So we'll have 3 this year. If you have any questions, please contact Bethany on info@theiscn.com. Bethany, maybe you could pop that in the chat and have attached. I also want to give a shout out to the Global Plant Council to thank them for this support and let us go into some of the consequences of some of these compounds, chemicals that plants make to defend themselves against herbivores, which of course is also very effective in defending themselves against humans. And I know the Global Plant Council represents plant science organizations from around the world. There are not many African organizations in it, but they are very much wanted and needed. So if you are on this, or you know people who work for an agricultural organization or plant breeding or a university in Africa, please contact Isabel Mendoza. Maybe Isabel put the contact details in the chat. I'm sure that they would be very, very welcome to hear from you.
So thank you, Isabel, for organising this. Thank you, Bethany, for your work behind the scenes. And thank you for everyone attending. It is inspiring, even if it's somewhat like, oh my goodness, where do we go from here? Because it's very, very hard to get traction on this problem and get these poor people to be made visible. Over to you, Isabel, to close off.
Yes, just a reminder about the certificates. They will be the certificates of attendance will be sent out during next week. Please be patient because it takes a lot of time to prepare them, but you will get them. Don't worry about that. And we will be preparing a next webinar for next month. We have to fix the date and fix the speakers, but we will see you together with the International Safe Cassava Network if in another two times this year. So thank you for your attendance, and I've included in the chat the link to the recording that is already available. And then you can share it with your peers if you think it's worthwhile. So thank you, and see you in our next webinar.
Thank you.
Thank you.
Thank
Bye-bye.
you.
Bye bye,
Bye-bye.
everyone.
Bye.
Bye, everyone.
Bye.
Bye.